Welcome, everybody, to the Azrieli Speaker Series, the March edition. We're really excited today. We're going to be hearing from Anna Durbin, who's a close colleague of mine that I've been able to work with over many years in different contexts. Anna Durbin is an assistant professor in the Department of Psychiatry at the University of Toronto, and she's very passionate about different creative ways to use data, to analyze data, to ask questions, to integrate different areas of research, and to look at things in different ways that maybe other people don't ask those same questions or get quite as. Anna's a very curious researcher, and also someone who's really passionate about translating knowledge in ways that people understand it. So she's going to be speaking today about her work in the area of primary care. And we're going to make sure that there's some time for us to have a really rich conversation after the presentation. So we're excited, Anna, to hear what you have to say, but we're also really excited to be able to talk about it after. So without further ado, Dr. Durbin, go for it. Thank you for doing our series.
Hey, welcome everyone. Thank you to Yona and everyone for having me. I'm quite thrilled to be here. So I'm going to speak today about a study that we have funded, but we have not yet really started. So it's a one time to be getting feedback on it, as we're still very much in the place where we can adjust course and make refinements as needed. So the reason I'm talking to you about the study is not only because I'm really passionate about primary care and supporting adults with intellectual and developmental disabilities, but also because I'm nominated principal applicant on a really wonderful team of, like, I'll call them the Harlem Globetrotters of primary care for adults with IDD. And I'll tell more about the team in the next couple slides, but we are trying to figure out which models of primary care are delivering the best outcomes for adults with intellectual and developmental disabilities, or IDs, I'll call them for the rest of the presentation. We're focusing on Ontario, and we'll tell you all about our project. Oops. Just trying to switch slides. There we go. So this is a mixed methods study, and it is grounded in health systems, equity, and it's a systems level inquiry. So it's really looking at primary care, but as its piece in the healthcare system, certainly not as a standalone. In fact, very much in how it relates to supporting people as they use other services, and are able to avoid use of some non-desirable services like hospitalization. And it builds on more than a decade of H-card research, which has looked at primary care for a long time, and we're going to get to that later in the study. But it's also really important now because we're responding directly to urgent policy questions about how we deliver healthcare in general, in particular primary care, for a population that is incredibly important and probably doesn't get the support that they need in many instances. So my co-leads on this project, oops, there we go, are the wonderful Yona Lensky, who provided a beautiful introduction. Me, you can ignore the purple lanyard. I'm working on the ChatGPT cartoons, but they're definitely coming along. So you've got me over on the side, you've got the wonderful Yona, and then we have Nicole Babette and Avra Selick, who are the qualitative leads. I'll be heading up the quantitative portion of the study. And Tiz, I was going to make one for you. I ran out of time, but the next time I do a presentation on this, you're going to have a cartoon as well. So I will be doing the quantitative, Avra and Nicole do the qualitative, and Yona sort of probably as usual does a little bit of everything and shepherds us through the grant process. So that's the plan, at least. So here's the core issue that our project is aiming to tackle, which is that adults with IDD have, as we all know, very complex needs that require interaction healthcare system, but at the same time, they're probably not getting the best care. And in fact, there's a lot of evidence of the array of barriers that they experience when they're trying to access timely and appropriate care. So we know this from lots of people, but we also know this from H-card, right? And we've shown with H-card that those with IDD are among people who oops, did not mean to do that. Sorry about that. That people are among the top 10% of high cost users. They're also 1.7 times more likely to be hospitalized for preventable conditions, 6 more times to have a delayed hospital discharge, which we know as ALC for most of us. They're less likely to get preventative care, and they're also more likely to experience premature mortality by about 4 times. So, primary care is often described as the front door to the healthcare system, and that's for very good reason, right? We are uh, frequently relying on our primary care providers. It's supposed to be our most consistent point of contact. And primary care, when it's firing on all cylinders, it supports health interventions, chronic disease management, and theoretically can reduce our reliance on emergency care and hospital care. But one of the problems is that primary care in Ontario is not the same for everybody. In fact, the number of ways that it can differ, and some of those are with the providers and some of those are with the bed types. So we're going to be focusing now on primary care models that differ in each of these, and we're really trying to cover with this project the full gamut of primary care models, as you'll see. So the first is interprofessional teams, and that is meaning that you have a physician, but they are working with others, their team, who are interprofessionals, allied health professionals, pharmacists, social workers, for example. We have the physician-only models, which are the models that were very, very common in Ontario until the 2000s when we had large-scale primary care reform. So that's what most of Ontario gets, which is you have a doctor and you have a doctor, right? They're not working with others. Sometimes there's others in their practice, but they're not working with this team of allied health professionals. Now you can also have nurse practitioner-led models, which are salaried nurse practitioners, and they are working with each other. There's no other specialists on them directly, although they can consult with like physician specialists, for example, who are external to the team. And they can differ in payment models as well. So we have fee-for-service. Fee-for-service models, we'll get into a little bit more. We'll get a little bit more into capitation, but the base of fee-for-service is that are paid per instance or per health issue that's brought up. So someone might have something that they want to talk about, and theoretically, the physician is only providing care for that particular issue. They are not incentivized by that model to provide broader, more holistic care. Contrast, capitation, and salary models, which again we'll discuss in greater detail shortly, are those that could perhaps incentivize physicians to provide quality care. So that's some of the things that we're looking at with this project is each of these different models. Okay. And I should say, not only are we looking at that, but we're also looking at the quality of care that people get and how these structures actually support the type of care. So let's take a closer look here at physician-only models, which still, as I mentioned, serve the overwhelming majority of Ontarians. So at least about 60% of Ontarians receive their primary care from a physician-only model, and it's split roughly equally between fee-for-service and capitation. And just as a quick reminder, fee-for-service pays doctors per visit. So as we said, they incentivize shorter visits and limits on what a physician is willing to address in a particular appointment. In contrast, capitation, which was introduced during the early 2000s in Ontario, pays a flat rate per patient. So if you're seen 6 times during the year, or 1 time during the year, or 12 times during the year, the physician would actually receive, for the most part, the same amount. There's a very small amount that would change, but over 90% of it is this fixed fee. And the physicians the way the capitation is set up in Ontario is funding formula for physicians does not change based on the patient needs. So if a patient comes in and they're quite high needs, that physician is not get paid more than a comparable patient who comes in here with very few healthcare needs. And these issues are, of course, for everyone, but they certainly also matter for adults with developmental disabilities who often require more time, coordination, and multidisciplinary teams to support them. Next slide. And in contrast, team-based models can look like family health teams, they can look like community health centers, they can also look like nurse practitioner-led models, and they, at least in theory, are more comprehensive wraparound supports. But we're not talking just about people with developmental disabilities here, we're talking about the entire population, and they only serve a relatively small percentage. So at most 30% of Ontarians right now are estimated to be receiving team-based primary care. And in family health teams, which are far and away the most common of the team-based models, physicians work with allied health professionals, as we mentioned, and physicians are paid via capitation. So as we said, they get that one fee for seeing the patient throughout the entire year. Community health centers serve about 2 to 3% of the population, but they are people who are supposed to be relatively complex, who live in relatively underprivileged areas, and they are funded via salary. So you have a physician who's salaried, and then they also have others on the team who are also salaried. So theoretically, at least, the incentives are for longer appointments, really more comprehensive care, recognizing that the patients who attend community health centers often have much more complex health profiles and social determinants profiles. And then there's nurse practitioner-led clinics. And honestly, they haven't been looked at a huge amount, the data sources that we're looking at. But what we do know is that they are supposed to be caring for people who might not be able to see a physician otherwise. So that might be based to geography. So a lot of them are in rural locations or underserved locations. It also might be to support people who are really not incentivized to seek physician care, or perhaps physicians are not able to take them on in their practice for whatever reason. So we have a number of options here for team models. I'll speak to more of them as we go through the project. Why am I so obsessed with team-based models, talking about it so much? This is the reason. So there's a recommendation which came from the 2018 primary care guidelines for adults with IDD, and it stressed the importance of holistic care. Included in that is team-based support, team integration, and having these different leadership structures that allow for greatest support for adults with IDD. So it's wonderful to have these recommendations, and I don't know if Betty Lynn's called, but she called it the face validity makes sense, right? This past smell test, you think that it makes sense for adults with IDD to be receiving this care. Problem is, when these guidelines were made, it was largely based on expert opinion, not a huge amount of outcome data. We knew to some degree what models people were in, what team-based models versus other models, not for all team-based models, but we don't know those are related to most outcomes. So that is a lot of what we're trying to do with this study. We're trying to see consistently people with IDD are actually able to access care, what that experience is like, and is it making a difference there, providing the better primary care that we think it should be, or is it really not making that much of a difference? And if not, why is that the case? So we're going to try to fill that gap in a number of different ways, and figure out, are these models, team-based models, actually working better for adults with IDD? As we go through, I'm going to describe to you the measurable outcomes, the pain points, how patients, caregivers, and their providers experience care within these models. The reason why we're doing this research right now is really because it is incredibly important. So there's been a confluence of a number of things that have come together that have showcased that this is something that there's not only to people with IDD, but across the board. And that was reflected in our CIHR scoring as well, which was very high, and not due to the presentation exclusively, although I think we put in a great proposal, but also because there's a recognition now in the political landscape and the healthcare landscape of the importance of this topic. So part of that is that Ontario's primary care team force initiative is really pushing for growth of the teams. And as I said, we think now about 30%, maybe even a little bit less of Ontarians currently have access to these models. We don't know how many adults with IDD have access. So that's something that is really important to know, right? If we know that 100% of adults are having adults with IDD have this care recommended, but 30% of Ontarians are actually able to access team-based primary care, those numbers are extremely far apart. So how many adults with IDD are actually getting that care? And we don't know if all team-based models are equal. For example, CHCs, community healthcare, as we talked about, are very, very different from family health teams. And family health teams are certainly more common, but CHCs actually support very complex populations, so maybe they are serving more adults with IDD. This research is really urgently needed to guide expansion of team-based models across the board in Ontario, and particularly to make sure that that expansion or even lack thereof really supports adult IDD. So let's make sure that we're filling out things that work, not things that don't work. This looks probably extremely familiar to probably almost everyone on this call. So this is the H-Card Atlas that came out in 2013, but it looked at data from 2009, 2010 full year. And at that time, the size of the cohort of adults with IDD was about 66,000 people. We'll speak later, but it's pretty much doubled almost exactly at that time based on our measurement strategy. And this is all done using administrative healthcare data that's housed at ICS. And again, we'll speak more about that as we get further and further into the weeds. As we can see here, at that time, most people were not in team-based capitation models. So this is what we learned from the study, and that was done, about 15 years ago. And each of these bars represents the prevalence of adults with IDD in each of these models, and then that little dashed line shows how many people in the general population, so who we think probably don't have IDD, were in those models. So as we can see, adults with IDD were slightly overrepresented in team-based capitation models, meaning that they were a little bit more likely to be in team-based capitation models than adults who don't have IDD. We see something very similar for capitation models that are physician-only capitation models. And then we see that adults with IDD are actually less likely to be in enhanced fee-for-service than the general population, but is still the highest number overall. So if you're saying what model is someone with IDD most likely to be receiving care from, it's actually not a team-based model, right? In fact, about 80% are not getting care from team-based models, even though people in team-based models with IDD are slightly more likely to be there than those without IDD. So I know that can be a little confusing for people who aren't data people. I'll keep trudging along unless someone has something that they'd like me to talk about. Okay. So that we found, or that's what H-Card found in 2009-10 in Ontario. There were some things that at that time were not able to be examined. So we're going to take a more detailed look at those things now. And one is comprehensive care. So what is comprehensive care? It's, as we talked about, not going to your doctor's office and saying, I have this issue, and the doctor looks myopically at that particular issue and then sends you on your way. Comprehensive care is really taking a much more holistic view of the individual and saying, if we put them on this medication, how might it affect some other parts of their life, etc. Right? It's looking broadly at supporting the individual's health and well-being. Then there's continuity of care. Continuity of care is really important for a number of reasons. First of all, as we all know, and sharing your story every time you go to the doctor, like if you are going to a walk-in, for example, or going to the emerge, anytime you're encountering a new doctor, you have to share that story anew, and that is very stressful. And it's also not associated with the best care outcomes. So continuity of care, especially if you have a lot of health issues and perhaps if communication is challenging or just stressful, as it really is for most people. You want to have better continuity of care. So you want to see that same physician or that same primary care provider again and again. They get to know you, they get to know your health issues. And then the last was hospitalization. So although representation of people with IDD in different primary care models was examined, does some model actually help to keep people out of the hospital was not something that was examined in particular during this work. It also focused exclusively on family health teams as the model of team-based primary care. So these models were small, and they still continue to be small, serving probably about 3% of the population, but they're actually really great to include nurse practitioner-led clinics and CHCs, as I've mentioned, because of their mandates to serve low-income, urban, and underserved communities, and they are paid, as we've discussed, in salary models, which might give them more time, and in combination with their mandate might really be a wonderful support for adults with IDD. All right, so we're going to focus on these two models, and we're going to focus on the models that we've already talked about, as you'll see ahead. And the issue of why we need to check again is not only so that we can look at what we wasn't looked at in 2009 or 2009, 2010. So as I said, we'll look at comprehensive care, we'll look at continuity of care, we'll look at hospitalizations as those relate to your primary care model. We'll also look at community health centers and also at nurse practitioner-led clinic. There's other reasons also, just in terms broadly of the healthcare landscape in Ontario, that really makes it very urgent to do this work and see how things have evolved over the past 15 years. So in 2010, primary care had evolved significantly, but there was lots more to do, right? The newest models had just been introduced. Family health had only been introduced about a year and a half earlier, and probably some of the patterns that are ultimately quite good today had not yet been established. Also, as we hear on the news all the time, there's fewer family physicians who are accepting new patients right now than ever. There's a lot of burnout, early retirement, a growing population, and primary care is just massively stretched. The other big change that we have had since this is the introduction of virtual care as sort of a mainstream option, right? So in 2009, 2010, virtual care existed, but it really was not commonplace modality of healthcare interaction that it is today. But we don't yet know enough about how well it supports adults with IDD, particularly in primary care settings and in team-based models. So although adults with IDD are, probably about 2% or so of Canadians, it's just really important work to be done to show how they're able to be supported, given the number of health issues that is common, and also that healthcare interactions can be extremely stressful. We know primary care is really important, and we know that there's a number of ways to support people. So let's take a further look into how we're proposing examining this with this study. Here is our big question. Do team-based primary care models really lead to better outcomes for adults with IDD? And we're not just looking at the model label, we're going to look at the functionality, or what is it particularly in the model that helps people get better care, or in some cases not get better care. Is it more proactive? Are they more likely to get annual health checks? What are those mechanisms that are actually leading to better outcomes in some models rather than others? And the way that we're going to do this is with a mixed methods design. So our quantitative component is going to use linked ICES data, and it's going to look at a lot of the questions that we've already talked about, but comparing adults with IDD who are, first of all, what models are they in? And then how are their experiences across models? And then very fortunately, we have Abra and Nicole to lead the qualitative components that will include in-depth interviews with patients, caregivers, and providers to understand their lived experiences in different primary care models. And from this, we're aiming to understand what's not working, what is working, and how adults with IDD and their caregivers can best be supported by Ontario's primary system. So Our quantitative analysis will draw on ICS data, as we mentioned. And as you probably guessed, we are going to look at these 5 outcomes because we didn't look at them before. And they're just really important things to know about. So continuity of primary care wasn't looked at previously. Virtual care wasn't looked at previously across models. The health tech is the version of comprehensive care that is now available. So although the general population is no longer eligible to like a full checkup every year, this is something that has recently been implemented for adults with IDD, and there's a new billing code that's just come out very recently over the past couple of years, and that physicians are really just learning about an option so that they can be paid for providing a once a year full checkup for adults with IDD, and then the roster status. And when we say roster status, we refer to whether or not people are actually getting the full benefits of the team that they're on. So if you are in a team-based model, but you are not rostered, you won't get the benefits of the team-based model. What models are they in, and are they actually rostered? The qualitative components, as I mentioned, is essential to this work, and we're going to use the admin data to show us lots of patterns, but it's not going to be able to tell us very well the structural elements and how they're shaping the patient experience or the provider experience. So because such an important part of the study that we're doing, we're also going to conduct 30 to 60-minute interviews with adult IDD. They can have a caregiver present if they wish, also their caregivers and providers, both from team-based models and from physician-only models. And very fortunately, I'm working with a number of colleagues who have extensive experience doing these types of interviews, so using accessible language and making sure, as I said, that caregivers can participate along with adults with ID if that's something that people are interested in. We're also exploring questions like how is care coordinated, how are interprofessional teams being used, are supports available when they're needed, and what does continuity care look like, or what does virtual care look like in real life. So these interviews will really help us understand not just if care is delivered, but how and what matters most to patient families and providers. So this is actually the last slide, and I'm going to open it up to questions. But this is truly integrated mixed method study. So the quantitative arms and the quantitative and qualitative arms will run concurrently, and then they'll be analyzed first separately, but then an integration will be done so that we can see how the findings come together. Do the data and the experiences match? Are there mismatches? If so, why might that be the case? And it'll help us explore the complexity and answer the critical burning questions. What works for whom, under what circumstances, and identify the actionable areas for policy and practice change, especially around team-based primary care, how we can best help move those forward. So as I mentioned, adults with IDD are obviously an equity-deserved population whose health needs are often overlooked or inadequately addressed. And our study hopes to be one of the steps to change that. And we are fortunate to be able to use Ontario's rich administrative data and center the voices of adults with IDD, caregivers, and providers. And hopefully by doing this project, we'll generate evidence that's needed to help inform primary care, as there's a lot of uncertainty ahead for how that looks and how that's going to be delivered. And to do that, we're going to work with a number of really, really smart people, including 3 advisory groups, which would represent self-advocates, their family members, and key system stakeholders. So the hope from working with all those very smart groups is that the research will be grounded, relevant, and able to mobilize it. So ultimately, this is a study about designing an important part of the healthcare system that actually works for people who need it most. And to be able to make recommendations on that, we need to do this work. So that's all prepared, and I'm looking forward to the feedback.
Thanks so much, Anna. So we can take the slides down. And it's a nice opportunity for us to talk about some of the things we heard. Now, few things that are kind of unique about this. One is that sometimes our speaker series has been focusing on sort of projects very, very late in the sort of trajectory, right? So sometimes we hear people presenting on things well after they finish the study, they've written stuff up, here we're sort of getting an opportunity to hear about why someone does a study and what sort of the plans are, the hopes are. So it's kind of at a different stage. But I think even before we get there, I'm curious because I'm looking at who's sort of attending here today. And we can maybe, Anna, do you want to take the slides down and we can just chat and
Yes.
see everybody when they
I
have their
thought I
questions?
had.
There we go. Now you have, it's perfect.
Yeah,
I'm
yeah,
just
no, I
wondering, and you
believe
could
that.
use the chat box or you could show your hands or whatever, like who understood all these nuances before around, we hear about primary care all the time in the news, that kind of thing. We know there's a shortage of primary care providers. We hear about a big new primary care plan that Doug Ford has invested in Ontario, and Jane Philpott is sort of the leader of this new plan. But who knew about these different kinds of primary cares before? And even the idea that there were some primary care teams versus not teams. I'd love people to maybe comment on that or raise their hands if this is sort of new information, not the study in our population, but just what primary care is in general. Anyone learned something today that they didn't know before? Because sometimes when you're focusing on this stuff, I think so much you don't realize how much people are aware of or aren't aware of. Know about the different fee structures. Yeah, thank you. And if it's complicated for us to know, you can imagine it's really complicated for people with developmental disabilities and their families to navigate and understand. And I should say, just as a little story, when we were preparing on this grant, also it's interesting to see how a grant kind of evolves over time and why you write a certain grant. So people might have all kinds of questions for you, Anna. I'm just watching the comments and getting people ready for the questions. But I remember asking one person about team-based care. I thought they'd be really good at potentially advising and being involved in the grant. And they said, oh, I have team-based care because after I see my doctor, I go in the elevator up to another floor and I see someone who helps me with my diabetes, or I get my blood work done. So to them, the team was the same building. It wasn't a team at all, right? It's just that they happened to be getting their care in a medical building. So they thought it was a team. And another person said, well, I have a team-based care because, there's different people who I think are part of my team, right? Like because I'm at the center of it, that must mean that anyone who helps me is part of my team. But that's also not the same thing as primary team-based care, right? So yeah, seeing all these comments, and I don't know if you can see those comments as well, that people are kind of learning. So yeah, and the funding thing
Yeah,
is important, right? Because it drives how people deliver their care based on how they're being paid. And people are not all being paid in the same way. Average just right. I work on this project, still not 100% sure what my own provider is. That's a good question. Who has primary care here? I have a family doctor. Does anyone have like a nurse practitioner or a family doctor? And who knows what kind of care they get? Do they know if they're part of a family health team, a community health center, um, family health organization, nurse practitioner clinic? Seeing some nods. Yeah. All right. No idea, said some people. I was so lucky to be studying this area because they built just at the end of my street. Some people have been to my house. There's one of the UHN Family Health Team satellite offices is like at the end of my block, and it went up. I was seeing a different doctor, in another part of the city, and I was like, oh my goodness, it's like a gold mine, a family health team, like right where I live, and I had my whole family switch over because I knew it was a different kind of care and potentially it would be sort of more easier to access certain kinds of things. So yeah. All right. So that was just my little ramble, getting everyone warmed up. What kinds of questions and thoughts do people have for Anna? And it could actually inform or drive what we do in the study because we're really just figuring that out.
yeah. So I'll just build on what Yona said is so I did my PhD in primary care, and I still learned doing the study. And the question of why does roster status matter? I probably asked like 100 academic clinicians before I actually got an answer as to why it matters. It's one of the confusing parts. You can actually be in a model without being rostered in the model, but then you don't get all the benefits of the model. So if you are in a team but you're not rostered, then you're functionally not in a team. And it was probably like 101st person that I asked who was able to explain that to me. So I know it's like a little bit of alphabet soup, but anyways, I'd love to hear feedback from people as to what they thought made sense, what things they think we should maybe pause and reconsider a little bit.
Go
Guess we
ahead,
can ask
Avra.
another.
Okay. If anyone else wants to talk, please, I don't need to be talking, but while people are kind of gathering themselves, thinking of their questions, I had a comment and I'll pose a question to Anna. So one comment was just to say, if anyone is confused, I have such a clear memory of like early on in my tenure with HCARD, back when we were working on, I think it was the Atlas, I remember sitting in this large room, a lot of really smart people who are policymakers, researchers, and people involved in primary care, and our analyst from ICS was trying to explain to us what all of these acronyms meant and the difference between a delivery model and a funding model and how sometimes they're the same and sometimes they were different. And like no one could wrap their head around it. So it's like, if this is confusing to you, it is not just you. And again, like there's zero chance that the average person on the street is going to understand what kind. I mean, you're just happy you can get a primary care provider. You're not out there saying, no, actually, I don't want you because you're only, under a general, mixed capitation fee for service model. And I want someone who's, like, so anyways, it's interesting to learn more about primary care. But my question for Anna is, what are you most excited about for this project? Like, what do you hope that we learn and how is that going to make a difference for people?
That's a great. I am very excited to see the CHCs and how the representation of adults with IDD and those adults. I think that's probably something everyone is very interested in, but because of the mandate and the salaried nature of the all the professionals, the physicians and the allied health professionals, it could actually be a wonderful support for adults with IDD. But we just like the data's there, right? They can look at adults with IDD and we can link data, but it hasn't been done yet. So I think hopefully the CHC is the model that really does do a job and that has like mechanisms that we can say should be scaled to other models, like to other primary care models, it would be a really good outcome. I can ask people a little bit more about their experience with primary care, which is, has anyone used a non-physician primary care service? Have you had a social worker who was part of your primary care team, or a pharmacist who you saw, or an occupational therapist? Because one of these that we can't measure, and this is something that I get to talk about, but it's actually a big source of frustration, is that we can't measure how people are using the care. So we can see if someone is in a primary care model, if they're in a team-based model or not, but we see how they're actually interacting with that model. And that's something, or not with ICES administrative data. So that's something Avra, Nicole, and others doing the qual research can look into. But I don't really know if people who are in family health teams are actually using those services. Anyway, Samantha, go ahead.
Thank you so much for your excellent presentation. It was very insightful and educational and beneficial to learn from. I'm a social worker on the Adult Neurodevelopmental Services outpatient team, and I'm trying to find GPs, psychiatrists, or other physicians in the community, and it's been like really difficult to find people. That generally you find people specialize in developmental pediatrics, and then there's no transition to adults. There's no such thing as like somebody that focus on developmental concerns for the adult population for GPs, and even like contacting major pediatric hospitals or agencies or service providers or like family health care teams, as most of them don't have no idea like who to refer to. A lot of them are generally consultative based, similar to our service as well, and it's very challenging to find long-term supports. I was just curious, from your research experience and your knowledge, like working in the different fields, do you have any suggestions as to like how to creatively like find physicians in the community that work with this population? Or have you found through your research, have families or individuals noted how they navigate the system, or how they kind of end up in the adult sector, and how they found access to care in that regard? Just kind of curious, just because I find it very challenging for myself to try to find that continuity of care for our clients to help them meaningfully, like across the lifespan through their adulthood. Thank you so much.
I think that's an extremely relevant question. So what we haven't talked about, but this is, I guess, my personal answer, is it would be wonderful if one of the deliverables from this work is perhaps a directory or some kind of centralized point where we have information on physicians who are known to support people with IDD, and you could have them, at different points in their life. So, yeah, pediatricians, people who are middle adults, older adults, etc. It's not something that we've talked before, but I think that it's not something that I know of. No, I know even just for the general population, wildly difficult. And when I was wearing a different hat over my maternity leave in the summer, I used Facebook and social media platforms, and I found about 80 physicians, like family doctors, or who were taking patients at that moment in Toronto. But that was not talking at all about developmental disabilities, and that was almost just a social experiment that I sort of did with my free time to see if we could create a centralized directory. And Facebook was absolutely the best source to get that information. It's certainly not how it should be, but I guess how it is.
Just to add, thanks so much for your question, Samantha. I think one thing we can probably do a little bit more is work with the folks at Surrey Place, for the people who are from CAMH here, in terms of what they're doing around primary care in our population. So there's two groups I would think of. One is the Developmental Disabilities Primary Care Program that's run out of Surrey Place, and they have a number of family physicians who are employed now at Surrey Place, and sometimes they consult to other doctors who are family doctors or primary care providers, and they need like a bit more specialist nuance. So those family doctors can give a bit of extra input. But sometimes they're also good at kind of knowing who is like more recent graduate, who's maybe looking for patients or who's comfortable with our population. So I think a little bit of the communication of our struggles with our colleagues at Surrey Place is one small strategy. And then the other small strategy I'm thinking of is there's a group called PONDA, which was originally sort of started around people who are developmental pediatricians, like you said, who kind of work with these folks when they're young. But PONDA is really interested as well in that transition into adulthood. So I think they have some ideas and are doing some advocacy. And they actually have like a meeting or whatever, a half-day meeting, and some of it is on this transition issue, and it's happening in about 2 weeks. So, yeah, it's a big barrier for sure. Anjali?
Thanks. Hi, Anna. Really nice presentation. It was wonderful to learn about all of the things that you're going to be doing with this project. One thing I wanted to ask about was like Ontario health teams, and if you kind of factored those into the equation, because I know like the landscape in Ontario for care is changing a lot, and for Ontario health teams, some community health centers and primary care models, like they're partnering with their OHTs, and they're sharing resources and moving people around like in the area using the Ontario health team. So I wonder if like that factors in, and if you've considered, based on like the years that you're going to be running the data for, if a organization was part of an Ontario health team or not.
It's a great thing to consider. I think we move forward, it'll be one of the pieces that we see if it's an influential sort of variable or not. I guess I at this point I don't know, but I agree with you. It would make sense, certainly, for it to be like a relationship, especially with a particular health team. It might be a relationship with any health team, and then maybe some particular ones that really are influential in the care that's provided. But yeah, I'm interested. I just don't know the answer now. There was a question in the chat around standards of how the health teams prioritize intake. There are, and please correct me, someone else, if I misspoken, but I believe there's basically no standards. So they can take, whoever they want. And the issue that you're raising of like a potential misalignment between who's actually getting team-based care and whether or not they are sort of the most stand to benefit the most based on their profile, is like a major issue, right? So yes, I think that's a big issue. The other problem with family health teams is there's not really standards around pretty much anything in terms of care delivery. So a family health team that has, a champion, and this is something that AVRA will look at, but like it'll be harder with the administrative health data at ICS. Like all family health teams might not be the same, right? They actually could probably, it would be reasonable for there to be quite a large amount of variation because there's standardization, and it might be like the presence of a particular provider or a relationship particular like OHT that actually is to providing some really fantastic care. So that's something we are very open to finding, but I don't know yet. And as Zaffer's put in the comments, it is often not the people who are the most in need of the care who get the care. So it's not a great system like that. It's actually a little bit frustrating, or a lot of it, because there is some evidence of what is sort of cream skimming, I guess, if you're taking a little bit more pessimistic look, but that means taking the healthier people and not taking the less healthy people, or taking the less healthy people but having them non-roster. I don't want to get too much into the weeds here, but because we have capitation models adjusted for age and sex, that means any 30-year-old female will be results in the physician getting this amount of money no matter how much they visit the physician. So, we're all humans, right? As a physician, you might be more inclined to take the 30-year-old female who doesn't have significant health issues because it's going to mean less providing that care. And that, I would say, that's a problem with the policy, like the way that human sort of natural incentives are. I think myself, is if I was a physician, like I would want to get home at the end of the day also. So you can't really do blatant screening, but there are, I think, also possibilities that it does occur, and evidence to that. Yeah, so one of the potential outs from this work certainly could be saying we are seeing that team-based models really do work for adult IDD, and in particular this subset of team-based models, and having things, for example, like standardized intake practices. So if someone IDD applies to a team-based model, they are prioritized, like that would be a very concrete outcome, and certainly might be something that we end up recommending.
Thanks so much. Any other questions for Anna? I'm noticing in the chat the comment that it's, this gap in services that even Surrey Place says they can't necessarily say these are the people you can see. But I wonder if we can sort of do some of that problem solving with them, even if they can't just give us the names of family doctors. It's something we can work on together. Yeah, same problems as well. No, we're all in this exact same ridiculous situation. So sometimes we use our data to highlight what the issue is. But I think, yeah, let's not give up. I will say, I do think when we can get her attention, I have faith that Jane Philpott recognizes why this is an important population to address in terms of them having good primary care. I think she really cares about the population. For people who followed what happened during the pandemic, I think she got very involved with Participation House when they had a massive outbreak. And I think she understands what some of these nuances are. And so somehow we have to report back on how impossible this is. And sometimes we can use data to highlight what some of the issues are. So I think that's the exciting thing about research. The frustrating part is how long it takes to do the research sometimes. And we don't have the answers as quickly, I think, as we would like. So any other final questions or comments? All right, well, thank you so much for presenting this work to us. Oh, I'm just seeing Aideen has a comment here. Yeah, so the lack of walk-in being attached to the team-based care. So do you want to elaborate on that? So is the issue that you can't, is it that there's two things I think that can happen. So I'm in a family health team and they do have like some evening and also Saturday walk-in, but they don't necessarily have something every evening. So you can go to a walk-in clinic, but when you're in team-based care, in fact, if you're with any provider, it's almost a disincentive for you to go outside of that provider to a different kind of walk-in clinic. So is that what you're
That's
thinking
actually
about?
what I was hoping for, the one that actually in my area that we could register with after a 3-year wait did not have any walk-in facility in the East End. So I'm not sure whether that concerns other ones, but that certainly was a factor.
Yeah.
Like the after hours care you're talking about, right? Yeah. Yeah. That makes sense. Because there's no standards, it's very like I think that it's you can, as you said, you have sort of the luck of the draw which access is near you and what they're offering.
There's also paid services, like Maple, that some people sign up for, where you can get primary care when you need it, but the person doesn't necessarily know you super duper well, but it's very accessible. And so some people, I think, will do those things also. Thank you for making us think, even though you got us a bit distressed, Anna. I think it was really interesting to learn, even if we're in mental health care, primary care is so key, right? It's a starting point. And when we have good primary care, it's probably good for all of our mental health. So appreciate you talking to us about the study. We look forward to hearing about how it develops over time.